Depersonalization and derealization disorder is an dissociative disorder, a type of mental illness. Look at this picture, shows that feeling of detachment. Look at this. And derealization. Then pathophysiology, disease mechanism. Look at this. A detail going on. Introduction, depersonalization and derealization disorder, DDD, is a dissociative disorder characterized by persistent or recurrent feeling of attachment from one's self, depersonalization, and from the surroundings, derealization. While reality testing remains intact. Although everyone experiences transient disassociation at times, DDD become a disorder when these experiences are prolonged or interfere with daily functioning. It can occur independently or as part of other psychiatric conditions. A definition: a dissociative disorder marked by persistent or recurrent episodes of depersonalization, derealization, or both, where in the individual maintain reality testing but feels detached from themselves or their environment. Depersonalization, a feeling of being an outside observer of one's thought, feeling, sensations, body or actions. Derealization, a feeling of unreality or detachment from one's surroundings. Example, the world appears foggy, dramatic, or visually distorted. Etymology. The term depersonalization is derived from the Latin word de meaning away from and persona meaning self or person, indicating a sense of detachment from oneself. Derealization comes from the prefix de and the word realization, suggesting a feeling that the external world is no longer real or familiar. Epidemiology. Depersonalization and rationalization disorder became a lifetime prevalence of approximately 1 to 2 percentage in the general population, with higher rates observed in individuals exposed to trauma or chronic stress. It typically begins in adolescence or early adulthood and affects both male and females, though some studies suggest a slightly higher prevalence in females. types, while DDD is a single diagnostic entity in DSM-5. It manifests through two main types for experiences. One, depersonalization, dominant feeling of disconnection from the self. D, realization, dominant perception that external world is unreal or strange. Some classify it based on onset and course. Primary DDD occurs as an isolated disorder. Secondary DDD occurs with other psychotic conditions, example anxiety, depression, PTSD, schizophrenia. Causes. The exact cause of DDD is unknown, but several factors are associated with its development. 1. Severe trauma or stress, example abuse, accidents, war. 2. Emotional neglect during childhood. 3. Substance abuse, example marijuana, hallucinogens. 4. Neurological factors, example temporal lobe, epilepsy. 5. Genetic vulnerability. 6. Personality traits, example avoidant, obsessive. Risk factors. 1. Childhood emotional, physical or sexual abuse. 2. Chronic stress or anxiety. 3. Depression. 4. Substance misuse. 5. Family history of dissociative disorder. 6. Traumatic events, example combat, car accidents. 7. High neuroticism or emotional sensitivity. Complications. If left untreated, DDD can lead to 1. Chronic anxiety or depression. 2. Social isolation and functional impairment. 3. Substance abuse as self-medication. 4. Impaired occupational or academic performance. 5. Poor quality of life. 6. Increased risk of suicidal ideation. Pathophysiology. Pathophysiology of depersonalization, derationalization disorder, step-by-step process, involves complex interactions between the brain's emotional regulation, perception and stress response systems. Below is step-by-step breakdown of how the disorder may develop and manifest. 1. Triggering event, stress or trauma, exposure to severe psychological stress, trauma or emotional overload, example abuse, accident, war. The brain attempt to protect itself by psychological distancing the individual from the distressing experience. 2. Activation of the HPA axis. The hypothalamic pituitary adrenal HPA axis become hyperactive in response to stress. This leads to increased cortisol production and stress hormone that can affect brain regions involved in perception and emotion. 3. Amygdala suppression. The amygdala responsible for emotional processing and fear response become hypoactive. This causes emotional numbing or detachment from emotions, a hallmark of depersonalization. 4. Prefrontal cortex hyperactivity. The prefrontal cortex, especially the dorsolateral and medial prefrontal regions, becomes overactive. This overregulation inhibits emotional responses and increases self-monitoring, leading to a sense of being an outside observer. 5. Disruption in sensory integration. Abnormal sensory processing occurs especially in the temporoparietal junction, which integrates bodily and environmental information, results in distorted body image, time perception, and sense of disconnection from self or environment. 6. Altered neurotransmitter activity. Dysregulation of serotonin, dopamine, and glutamate contribute to changes in perception and mood. May explain symptoms like emotional blunting and visual distortions. 7. Persistent disassociation. Over time, the brain adapts to this disassociative state as a default coping mechanism. The individual experiences chronic or recurrent episodes of depersonalization or derealization even without a current stressor. Summary flowchart: stress trauma, HB axis activation, amygdala suppression plus prefrontal cortex overactivity, impaired sensory integration, neurotransmitter imbalance, and persistent disassociation. Signs and symptoms: 1. Persistent or recurrent experiences of feeling detached from one's body or mental process, depersonalization, feeling that the surroundings are unreal, derealization. 2. Time distortion, time feel slowed down or speed up. 3. Emotional or physical numbness. 4. Sensory distortion. Example: sound seem muffled, 5. Reality testing remains intact. 6. Difficulty describing feeling or sensations. 7. Feeling robotic or in a dream. Diagnosis diagnosed based on 1. Clinical history and symptoms, DSM-5 criteria. Rule out other mental disorders, example schizophrenia, panic disorder. Rule out substance induced states. 2. Psychological assessments such as dissociative experience scale, DES, Cambridge D, personalization scale, CDS. 3. Neuroimaging in research to rule out neurological causes. 4. Laboratory test to rule out metabolic or toxic causes. Nursing diagnosis. Examples include 1. Disturbed personal identity related to depersonalization experiences. 2. Anxiety related to unfamiliar and frightening experiences of unreality. 3. Ineffective coping related to chronic dissociative symptoms. 4. Social isolation due to emotional detachment. 5. Impaired social interaction related to altered perception of reality. Medical management. 1. Pharmacotherapy limited efficacy. SSRIs example fluoxetine, sertraline for anxiety or depression, lamotrigine anticonvulsant in some cases, naltrexone opioid antagonist emerging use. 2. Cognitive behavioral therapy CBT gold standard. 3. Mindfulness based therapies. 4. Transcranial magnetic stimulation TMS experimental. Nursing management. 1. Establish trust and rapport. 2. Provide a safe, non-judgmental environment. 3. Encourage expression of feelings. 4. Help the patient identify and challenge distorted thoughts. 5. Educate the patient and family about the disorder. 6. Support in developing grounding techniques. Example sensory exercises. 7. Monitor for suicidal ideation. 8. Encourage social interaction and structured routine. Treatment options. Psychological therapies. 1. Cognitive behavioral therapy CBT. 2. Psychodynamic psychotherapy. 3. Mindfulness based cognitive therapy MBCT. 4. Eye movement desensitization and repressing EMDR if trauma is involved. 5. Supportive psychotherapy. Medications SSRIs, benzodiazepines, short term use for anxiety, lamotrigine in some studies, naltrexone, experimental use, psychosocial medicine. 1. Psychoeducation, educating the patient and family about the disorder triggers and management techniques. 2. Grounding techniques, strategies like focusing on sounds, textures, and physical sensations to reconnect with present moment. 3. Stress reduction techniques, deep breathing, meditation, progressive muscle relaxation, and yoga. 4. Cognitive restructuring, helping the patient reframe negative or distorted thoughts about the symptoms. 5. Social skill training, enhancing interpersonal skills and reducing isolation to improve social functioning. Prevention. While DDD cannot always be prevented, risk can be reduced through 1. Early intervention after trauma. 2. Promoting healthy coping mechanisms. 3. Reducing exposure to drugs and alcohol. 4. Managing stress and anxiety. 5. Therapy for childhood trauma. 6. Building resilience through family and community support. In conclusion, depersonalization and derealization disorder is a challenging yet often underdiagnosed dissociative condition. Although it does not involve loss of reality testing, it significantly impacts a person's emotional, social, and occupational well-being. Early recognition, psychoeducation, therapy, and supportive care can greatly improve outcomes. An interdisciplinary approach involves medical, psychological, and nursing care is essential to help patients regain a sense of reality and live fulfilling lives. Thank you. Have a nice day.